Good day. Let me follow up with just a few things that you heard. I did retire June 28th, and right as I was turning 61, I said, so what am I going to do with myself? And it seemed like I'd want to stay home some, and after a few weeks my wife said, maybe you need to find something else to do. And so I began checking patients in over at the Cancer Center not so long ago. And to put a human face with this is that during that very first day, one of the patients I checked in was born in 2001. And I couldn't believe I was checking in somebody who was about 18 years old, and then as old as 96. So there's a real human face to what we're doing over with cancer. So as we talk through that, everybody has a life attached to it. And I thought, well, gee, that's 10 years younger than my youngest daughter. So as we work through the cancer system, or the cancer needs, it's amazing to see what a job they are doing over there. They've got 28 stations where they can give IV chemo at a time. So there's a lot of cancer in the area. And I was a little surprised to see both how young they were and how busy they were. So I'm really happy to be part of this cancer event. So with that in mind, about 30 years ago, I came here from South Florida with Dr. Coward, and we began doing diagnostic cardiac catheterization. And during that year, we saw 300 patients. This last year, we've seen quite a few more. During that interim time, we have been awarded top 100 for cardiovascular, stroke, and orthopedic care, not once, but several times. In 2004, we began putting more than one doctor in a room so they could coordinate the care for the Chest Center of the Carolinas. They were specifically looking at types of lung cancer. So that really began the big change as we began to put radiologists and surgeons and other providers in the same room. So last year, we treated over 5,500 patients in the cardiac cath labs, of which 400 went on to require open heart surgery. Again, as we've grown for the 30 years, we went from a very small program to one of the 10 largest in the States, as we've introduced new technologies, which has then driven the need for new beds. The Reid Heart Center was an $80 million check that Kathy wrote for us. I really appreciate that, Kathy. Which has about 80 inpatient beds and a number of rooms. Half of the cost when you build a building like that is due to the bricks and mortar, and the other half is things that you put inside it. And we have a picture or two of some of those things that are inside it. I do want to mention again, the number one killer for men and women is still heart disease. Now, if we continue with the projections that we see, within a few years it will become cancer. So as we begin to think about, as we focus our resources, heart disease will no longer be the number one killer, certainly within the next 10 years, as we are getting very good at treating myocardial infarctions. They then will go on to maybe have heart failure, but the number one killer will soon be cancer. So 5-star examples of innovation, philanthropy, and collaborative care is what we do in the centers. We have a number of those clinics that are multi-specialty, including the valve clinic, the chest clinic, and the multidisciplinary cardiology clinics, which does everything from diagnostic, nuclear studies, all the way through open heart, a single clinic. We have 6 state-of-the-art operating rooms. We also have 2 hybrid operating rooms. We also have 5 cardiac cath labs, and we have the region's most advanced electrophysiology equipment and procedures. Those rooms allow us to do things with a laser that literally burn up the extra places in your heart that makes extra heartbeats, those cells. So we're using lasers to ablate those extra cells. We also use the hybrid ORs to be able to treat people with the most advanced vascular disease in the safest way possible. We use a stent inside the artery, hopefully opening up your aortic vessel where we will not need surgery. So there's been a real vision and investment with this. None of this comes cheap. The thoracic and vascular care is by multiple providers. There are over 10 physicians who are part of that team. We have integrated cardiac and thoracic care services. They all share the vision to be the best. And the value is they work as a team. Each one values the efforts of each of the others. We continue to do research, and I believe Dr. Pritchett will talk to you about that, but we were the very first ones to do that type of cancer treatment in the region, and it's been interesting to see them fly in from Germany and other places across the globe to learn what we do best here, which is that radio frequency ablation of a lung. What is the valve clinic? Well, your heart has 4 valves. The 2 that give us primary problems is your aortic valve and your mitral valve. To do that, surgeons have traditionally replaced them. You may have heard about a pig valve. Cardiologists are used to placing small stents inside vessels, so each one did something a little different. So now that we put them together, we have surgeons and cardiologists who now can replace your valve through your groin with a new metal valve with a much lower incidence of complications. That is what a valve clinic does. Do we need to use a pig valve? Do we need to use a metal valve? Or can we use something that's through your groin? The groin length of stay is about 2 days. Open heart surgery, 6 or 7 days. Complication rates, instead of being 10% for open heart, are about 2% for the valve surgery done through your leg. We have all of that specialty care under the Reid Heart Center roof. It allows for very quick, multidisciplinary look at your specific disease. The next generation of heart care. Well, we've touched on a little bit of it. The best open heart surgeons have traditionally used a vessel from inside your chest called a mammary artery. Now we're adding the ability to use your radial artery. These vessels stay open longer because they're arteries. In the old days, we would use veins from your leg. They wouldn't stay open as long. They were veins. The artery is much more similar to what is already God given to you in your coronary arteries. We're going to focus on those fancy valve fixes through your groin, which we call TAVR, transcatheter aortic valve replacement. When we work on a lung, we do it with those video cameras you've seen so much about. They're very tiny. And they are video-assisted thoracic surgery and robotic thoracic surgery. So you can imagine taking pictures with something the size of a pencil lead and a robot then going into the lung, sectioning out each lobe, getting to the bad spot, closing everything up with an incision that looks like the length of a finger. Very different than going in there and taking a lobe out. You can imagine how that improves the quality of life in just a few days. Additionally, for patients that were too sick and couldn't stand to have a big lung surgery, you can imagine we can now treat these people that were untreatable and we were kind of signing their death certificate. So this is new technology enabling us to really save people's lives. Other things we do inside your heart is you can have holes between the chambers. Babies are born with them. Sometimes adults develop them. And what we do is we will then close those in the cath lab with a metal mesh that allows the chambers then to beat normally, so the blood goes in the right direction and not in the wrong direction. And it's like filling the hole in a pool. You'd fill it up and it wouldn't leak in the wrong direction. Those are called atrial septal defect closures. The last thing we do in that group is, remember, your heart has 4 chambers, and like everything else, like the people in the room, they need to work together. So we want to synchronize their activity so the first one goes and the second one goes, the third one goes, and the fourth one goes. When that happens, your heart's working as a single unit and you're able to pump more blood. We measure that output in liters. A normal output may be 2 or 3 liters a minute. We are able to sometimes double that to 4 or 5 liters a minute. What does that mean to you? It means people who could maybe make it to the front door and get short of breath now can walk all the way to their mailbox. You get twice as much activity before you get short of breath or feel like you can't go on any further. And that's CRT therapy. Well, you've gone to the doctor and your valves are not working well. So what's the next step? We hold a specialty meeting We get the surgeons and the cardiologist in the same room. We look at the 3 different types of devices that can fix it. We talked about the surgical approaches in your leg. And then we decide what is best for you. If it is done through your groin, it's with minimal or conscious sedation. That's the same kind of sedation you might have had for your colonoscope or your GI procedure. You give you a little something that's just for 10 or 15 minutes. You go back to ISU, a step-down unit, and you get to go home the next day after your valve surgery. Isn't that amazing? Mitral clip happened 4 days after I left. It was amazing. The mitral is the second most commonly fixed valve in your heart. And what happens with that particular valve is the valve should open and close. And for some people, it's open and stays open. So the mitral clip clips it together. We do that again through a groin procedure, which allows us to clip those leaflets together, and therefore the blood goes the right direction. Again, we want the blood to pump forward and not regurgitate in the other directions, and that causes heart failure. We've put in several of those, and they've all gone quite well so far. We expect to continue to do that a number of times a year, the mitral clip procedure. Lung cancer is the region's most prevalent cancer. 8 years ago, thanks to you all, we obtained additional fundings for bronchoscopy and bronchial ultrasound. Without it, it wasn't part of the capital budget. We didn't have the money. But through those first 2 pieces of equipment and using those high-tech hybrid ORs, which allows X-ray imaging, this imaging, which seems to be lights, the easiest way to describe it, and sound imaging, we can now look and see the exact area where you have a problem in your lungs. This was our very earliest in the pioneering approach with bronchoscopic radiofrequency ablation. In a nutshell, it causes waves to make that area hot again and burns the extra cells so they no longer are there. They can't duplicate if they don't exist. The Chest Center of the Carolinas brings multiple specialties into the treatment of lung cancers, also mediastinal tumors, which are those kind of right below your sternum, and other benign diseases of the chest. It allows people to get a single visit to get many, many things done the same day, instead of over a period of weeks seeing this specialist and that specialist. So it allows that to become much quicker, much more coordinated. And weekly they get together and talk through what they've seen during the week so they can make a decision. So at least your longest turnaround is a week, as opposed to it used to be measured literally in months. So it really causes things to go quicker and decreases anxiety and allows for just a better product as we do the best thing for the right reasons. Again, Dr. Pritchett, it's amazing to see these people fly from all over the world here to learn what we already know. The cone beam CT with bronchial ultrasound, which is that specialized imaging equipment we mentioned, allows us to see the very smallest of things in ways we can't. I describe this as looking at the Walmart. The front of the Walmart looks one way with the people wearing masks. The back of the Walmart has other things in the back. These allow us to, again, look at pictures in multiple different ways to make sure what we're seeing is what is really there and not just a two-dimensional image of a 3D problem. Dr. Pritchett attended the first in-man endobrachial microwave ablation in London with Medtronic. And we were the first to use a trial of the new wave endobronchial microwave ablation system. In 2015, the ALCF gave First Health Moore Regional Hospital a Community Center of Excellence recognition that assigns the highest level of disease placement and disease treatment to any community-based program in the United States. And that's what I have. Those are the things we've done. But let me just kind of wrap things up with you. 30 years ago, we did very little coronary artery disease. We saw 300 patients. This year, we'll see close to 6,000, 20 times more. The number one killer remains heart disease, but the mortality rate is measured in people per 1,000 because everyone dies of something. Those days, there were 300 people per 1,000 would die of heart disease, known heart disease on autopsy. That rate for this county now is 169. Did that happen for any one thing we did? Absolutely not. But it was bringing together the right people, the right resources, the right bricks and mortar, and purchasing the right technology that allows that to happen. Only through the efforts of the foundation, getting the word out about things to look for, and working together with the community, will we be able to continue to drive that mortality rate of heart disease, and now for cancer, down further and further, making people live longer. The final statistic I'd like to give you is the average life expectancy in Lumberton, Robeson County, banded by either sex or nationality, creed, is 10 years shorter than it is in this county. The average, and I will speak to my group, people who look like me live 72.9 years there, whereas in here it's almost 86. If you take anybody else and band it the same way, 10 years shorter, just an hour down the road. Do we make a difference? Absolutely.